All right, guys, thanks for joining me. Going to try to keep this pretty informal. So if you have any questions at any point, feel free to interrupt. But I've been asked to give a talk regarding imaging in acute ischemia. So this will specifically be dealing with acute cases up to 24 hours. Our goals and objectives for today, we're going to do a quick review of anatomy. I think by this time, most of us know the anatomy fairly well, so won't dwell on that. We're going to briefly discuss some of the trials that have led to our current imaging algorithm. We will discuss the role of diagnostic imaging in the assessment of patients presenting with acute neurologic deficits, and we'll outline our current imaging algorithm at McMaster/Hamilton Health Sciences. No financial disclosures, just to note that we do use rapid perfusion software, but I don't get any remuneration from them. So brief review of the anatomy. Obviously, we have our typical or conventional anatomic structures with the brachiocephalic artery and right common carotid coming off that, left common carotid coming off the aortic arch. We have our verts coming off the subclavian arteries, and then a complete circle of Willis with PCOMs and ACOMs. That's our sort of prototypical or conventional anatomy. There are tons of anatomic variations, which we won't discuss in depth here, but we've all seen bovine arches or direct origins of the left vertebral arteries, aberrant right subclavian arteries, lots of anatomic variation within the circle of Willis, fetal types, fetal origin PCAs, hypoplastic or absent PCOMs, and hypoplastic or absent ACOMs or A1 segments. There are duplications of arteries, fenestrations, etc., that can all give different appearances of the circle of Willis. These are our conventional vascular territories. Our ACA typically covers the parasagittal, frontal, and parietal lobes. PCAs cover a portion of the parietal and occipital lobes, as well as our inframedial temporal lobes. And then the MCAs provide the majority of the circulation to the bilateral cerebral hemispheres. Just a few specific arteries, our lenticulostriate arteries or branches off the M1 segments typically supply a large portion of the basal ganglia, and our anterior choroidal arteries as well supply portions of the basal ganglia. Posterior circulation, we have perforators off the pons, which supply, perforators off the basilar artery supplying a portion of the pons. We have our pica, ICA, and SCA territories. So just a quick review of those. There's slightly more in-depth circulation or vascular territories for the midbrain and pons. Perforators typically are the paramedian pons, whereas the superior cerebellar artery covers a portion of the lateral pons. And our anterior choroidal artery actually gets a portion of the anterior midbrain, and PCA supplies the majority of the remainder of the midbrain. Just a little bit lower down, this is again getting sort of into the nitty-gritty, not necessarily need-to-know stuff, but certainly useful. Again, perforators in the basilar and the medulla, and we have our PICA supplying the dorsolateral medulla, which is important in vertebral artery dissections. There are a few specific patterns or specific territories that sometimes come up. The long insular artery is a mimic of lenticulostriate artery. Infarct, however, is actually a branch off distal M2. Just remove this here. So you can see this is a lenticulostriate infarct on the bottom. It has a nice curvilinear appearance. Looks fairly similar on the axials. So having a coronal diffusion, which we often don't do, is quite useful. Our long insular artery actually comes from the insula and goes straight across. It's more of a parallel infarct. Recurrent artery of Hübner is one that often comes up. So it's a medial lenticulostriate branch off the A1 supplying the caudate head and anterior limb of the internal capsule. Artery of Percheron is another common one that we will often see and often comes up in exams, etc. It only occurs in about 4 to 12% of the population, but it's a single arterial supply of both thalami. They typically present with the classic clinical triad of altered mental status, memory impairment, and vertical gaze palsy. So about 9 years ago, the whole landscape for imaging acute ischemia changed, and there were a few landmark studies that came out. So prior to 2015, the goal of imaging was basically to exclude contraindications to TPA, and now it's basically used as a triaging modality for endovascular thrombectomy. So it was a very large shift in the approach to imaging acute ischemia. So right up until the middle of the last decade, patients presenting with acute stroke had limited proven treatment options. Thrombolysis was a groundbreaking treatment when administered within the window, but patients outside the window really had no effective treatments. Patients with large vessel occlusions also tended to have very poor responses to TPA just because there was such a large burden of clot to actually bust, so it was tough to get it in time to salvage the brain tissue. Then right at the beginning of 2015, there were several trials that began emerging showing the efficacy of endovascular thrombectomy in treatment of acute anterior circulation stroke with large vessel occlusions. So as a result, the approach to imaging changed from basically excluding hemorrhage and tumors to selecting appropriate patients for endovascular treatment. So this is just a list of the trials. We'll go over them fairly quickly. I don't want to dwell on them. It's no images, so it's kind of boring for us radiologists, but they're important studies to look at. So Mr. Clean was the first to come out. That was January 1st, 2015. They had about 500 patients with proximal arterial occlusions. They included A1s, A2s, M1s, and M2s, all within 6 hours of symptom onset. They were a pretty equal randomization with 233 patients in the treatment arm, and their primary outcome was functional independence at 90 days, as judged by the modified Rankin scale of 0 to 2, which we'll go over in a second. They determined that there was functional independence in 32.6% of the treatment arm versus 19.1% in the control. So an odds ratio of 2.0 is a significant finding. So basically, this is the intervention group, and this line right here is functional independence. So you can see the shift from the control group to the intervention group. There are a substantial number of patients who regain functional independence after endovascular thrombectomy. This is our modified Rankin score here, just for those who aren't aware. A 0 is no symptoms at all. 1 is no significant disability despite symptoms. They're able to carry out all duties and activities. A 2 is slight disability. They can't do everything they did previously, but they're able to look after their own affairs without assistance. And then a 3 through 5 is varying degrees of disability without being able to be functionally independent. And 6 is dead. So any shift towards 2, 1 or 0 is obviously a benefit both for the patient in their independence as well as for the system. The Escape trial, it came out slightly later in March of 2015. It included patients with proximal anterior circulation occlusions, M1 or proximal M2, with aspect scores of 6 or greater and moderate to good collateral circulation. They included patients 0 to 12 hours post-onset, but had very few patients at the 6 to 12-hour window, so it wasn't powered to assess that group. They were randomly assigned to standard of care versus standard of care plus endovascular clot retrieval, and they stopped early due to efficacy. Their primary outcome was also the modified Rankin score at 90 days, and they showed a 53% functional independence in the treatment arm versus 29% in the control. So again, a statistically significant number. They also actually showed a mortality benefit, which was one of the few studies. They had no significant difference in symptomatic intracranial hemorrhage. So again, just showing the modified Rankin score. So the intervention, obviously, we had a substantial number of patients who were able to go back to their lives, substantially more than in the control group. Extend IA also came out in March of 2015. Again, randomly assigned patients with ischemic stroke within 4.5 hours to alteplase and endovascular thrombectomy. They were stopped early due to efficacy with 70 patients recruited. They had patients with ICA or MCA occlusions with evidence of salvageable brain tissue and an infarct core of less than 70 milliliters on perfusion imaging. So this is one of the early studies using perfusion. Their primary outcomes were reperfusion at 24 hours and early neurologic improvement, and had secondary outcomes of the modified Rankin score with functional independence. Their median reperfusion was 100% at 24 hours in the treatment arm versus 37% in the control, which again sort of speaks to the inefficacy of TPA in these large vessel occlusions. Early neurologic improvement occurred in 80% in the treatment arm compared to 37% in the control group, and improved functional outcomes at 90 days was 71% in the treatment group and 40% in the controls. So again, significant improvement in patient quality of life. Revascat came out in June 2015, so all of these studies started pouring out as soon as they started seeing positive results in the initial. So they targeted patients with proximal anterior circulation arterial occlusions without large established infarcts within 8 hours of symptom onset. They were stopped early due to equipoise after the positive results. They received either medical therapy or medical therapy and thrombectomy. Their primary outcome was severity of global disability at 90 days on the modified Rankin score. And again, they showed significant improvement with functional independence in 43% versus 28% in the control arm. And again, no significant difference in mortality or symptomatic intracranial hemorrhage. Swift Prime, again, this is all sounding quite similar. They had patients presenting within 6 hours of symptom onset with confirmed proximal anterior circulation occlusions, ICA or M1s, without large ischemic cores on rapid. They were stopped early due to efficacy, and again, they had a rate of functional independence of 60% in the intervention group versus 35% in the control group. And again, showed no difference in mortality or symptomatic intracranial hemorrhage. So these early window trials showed that it was an effective treatment for anterior circulation ischemia due to large vessel occlusions, and a mortality benefit was only seen in the ESCAPE trial. They had no significant increase in adverse events. So following this, research began to be performed on whether we could delay this and give people in the later window a bit of a treatment option. So in 2018, these studies started coming out. The DAWN trial came out, which was focused on extended window endovascular treatment at 6 to 24 hours in patients with clinical deficits, which exceeded infarct volume by imaging. So they used rapid perfusion software. Their trial was stopped at the time of their predetermined interim analysis. They had 206 patients recruited with 107 in the treatment arm. They had an improved utility rated modified Rankin score of 5.5 in the treatment group versus 3.4 in the control, and improved rate of functional independence with 49% in the treatment group and only 13 in the control group. Again, so showed no change in mortality at 90 days and no change in symptomatic intracranial hemorrhage. And Diffuse 3 also came out in early 2018. They focused on the extended window from 6 to 16 hours who had ischemic tissue that had not yet infarcted. Again, perfusion imaging was necessary. Patients had to have ICA or proximal MCA occlusions with established infarcts of less than 70 cc's and a ratio of ischemic to infarcted brain of greater than 1.8. They enrolled 182 patients with 92 in the treatment arm. They were stopped early due to the results of the DAWN trial. So thrombectomy was associated with favorable shift of distribution of functional outcomes with a higher percentage of patients in the treatment arm functionally independent at 90 days, 45 versus 17%. They actually showed a mortality benefit in this study and no significant difference in adverse events. So basically, these studies showed that potentially up to 24 hours endovascular thrombectomy could be an effective treatment option for patients with large vessel ischemia with salvageable brain. This is just a summary slide of all the early studies. This is basically all the summary slides just showing the degree of improvement in modified Rankin scores over all 7 of the studies. So endovascular thrombectomy. When appropriate patients are selected, EVT is significantly improving the quality of life for stroke survivors. And imaging now plays a key role in the selection of these patients. So why do we image acute stroke patients? Number one, we want to exclude hemorrhage. Obviously, don't want to TPA or treat any patients that are presenting symptomatic as a result of their hemorrhage or have hemorrhage as a result of their infarcts. We want to exclude other dangerous mimics. Mainly, we want to exclude intraaxial masses or intracranial masses that may predispose the patient to bleeding. Once these dangerous stroke mimics are excluded, we want to look for primary or secondary signs of ischemia. So we look for our loss of airway differentiation, local sulcal effacement, hyperdense vessels, and gaze deviation. So this is obviously our sulcal effacement, loss of airway differentiation. This is fairly established. We typically like to see them a little bit before this. Hyperdense vessels, important to look on the standard brain window, so the 80-40 window for this, as all vessels will look a little bit bright on your stroke window. Gaze deviation, so patients will often have gaze deviation towards the side of ischemia, which is an important clue if you don't have a clinical history, especially as to the side of deficits. And then the other thing we need to do for EVT is we want to grossly quantify the extent of established ischemia. So with the acute window, we do this with the aspect school, which was created by the folks out in Alberta. Basically, it's a 10-point score or a 10-point scoring system with one point each for 6 areas of the MCA territory. So you have your M1, M2, M3 in the ganglionic, and then M4, M5, M6 in the supraganglionic regions. You get 1 point for your insula, 1 point for your caudate, 1 point for your lentiform nucleus, and 1 point for your internal capsule. Yeah, Derek, go ahead.
Sorry, I'm so sorry, and I couldn't unmute. My screen froze. Ian, just 2 questions. I often find it really confusing when the patient already has a lot of ischemic change or a prior infarct. Are we to include those areas of ischemia in the aspect score, which is not necessarily acute? Because how does that help? Because, do you know what I mean? Or are we to exclude them?
So no, you would include them. You would include them because basically you're trying to quantify the amount of potentially salvageable brain. So you want to know how much brain is actually already infarcted. So if they had a giant, like say they had an aspects 2 to begin with, you'd have to say, there's an aspects of 2, but it's predominantly chronic ischemia. I would just sort of qualify it with that.
Oh, I see. Okay. And the next question here, I'm sorry to dive. And the other thing was, we've had some cases where you can't see, this kind of really throws the rads, and we're kind of tearing our hair out saying, well, the perfusion is telling you thrombectomy is indicated, yet there is no vascular occlusion anywhere.
Sorry, you cut out for a bit there. You're talking about cases where there's a large area of ischemia or apparent ischemia on perfusion-weighted imaging with no, or on perfusion imaging with no large vascular occlusion, correct?
Yeah, yes. Why does that happen? And because it really confuses us, right? Because the perfusion is saying thrombectomy indicated, but there is no clot. So is that slow flow, or are we missing pathology?
It can be slow flow. Certainly you can have cases where you have a significant stenosis more proximally that's not intracranial. So you have to make sure you're looking at all the vessels if you have a severe carotid stenosis or proximal occlusion. That can be one case. Other cases, you get motion, which especially if there's bilateral perfusion defects, you really want to look at the motion maps on perfusion. I think there's a dedicated talk on perfusion in the half-day schedule. I'll have to double check that. If not, I can come back and circle the wagons on that. Yeah, check the motion maps as well, just to make sure that it's not motion related. Other causes can be seizure. Certainly you can get increased perfusion in the affected cerebral hemisphere if you have seizure-related activity.
Okay, thank you.
No problem. All right, so yeah, just as far as aspects goes, remember just to look through the entire MCA territory. Don't just concentrate on the MCA territory. Look at the other territories. We'll discuss that a little bit later, but just quantifying the amount of ischemia within the MCA territory. An example case. This guy's not doing so well. There's loss of gradient differentiation in your M1, M2, M3, your insula, your lentiform, your internal capsule, your caudate, your M4, 5, 6. So this is an aspect of 0. Another example case. So we have early loss of gradient differentiation within the insula and a small amount in the M2. So this would be an aspect of 8. And then we want to quantify the amount of salvageable tissue. After establishing the amount that's infarcted, we do this in the acute window with collateral scoring and in the delayed window with perfusion imaging. So collateral scoring. Our acute stroke protocol involves a CT angiogram from the arch to the vertex, followed by 2 acquisitions through the brain at 8-second intervals, basically getting the early and late venous phase. On the triphasic CTA, collateral flow can be scored by assessing the backfilling of arteries distal to the site of occlusion and comparing them to normal contralateral cerebral hemisphere. It's a scale of 0 to 5, where 0 represents no collateral flow and 5 represents essentially normal flow distal to the site of occlusion. And it can be simplified into good, intermediate, and poor. So what are good collaterals? Collateral score of 5 indicates that there's no delay of contrast in normal to increased caliber vessels distal to the site of occlusion. This is a good example of it. This is phase 1, so this is the arterial phase. And you can see there's essentially no difference in the classification of the distal MCA branches. There is an M1 occlusion distally, but you don't notice it when you're not looking at the actual clot. Collateral score of 4 indicates that there's a delay of 1 phase of filling of the distal vessels, but the caliber is maintained. So you look at phase 2 and it looks Exactly. The affected cerebral hemisphere looks exactly like the phase 1 of the non-affected hemisphere. Intermediate collaterals, score of 3 indicates a delay of 2 phases in filling, but prominence and extent are the same as the contralateral side. So basically it looks normal, but just not till the second phase. Or there's a delay of 1 phase with some decreased caliber and reduced number of vessels in some part of the occluded territory. So you can have a few areas that don't quite have the perfusion or the extent of opacification as you would expect. A score of 2 starts to indicate a little bit worse collateral. There's a delay of 2 phases with decreased prominence and extent, or there's a 1 phase delay, but some regions of the territory do not demonstrate any vessels. And then poor collaterals. A score of 1 is just a few vessels in the territory on all phases, and 0 is no vessels in the territory on all phases. If you only have a single phase, few or no collaterals to greater than 50% of the MCA territory, you could consider as poor collaterals. Just 1 second, just want to make sure I don't lose my axe. It sometimes closes on me. Okay, so here is a comparison. So good collaterals, obviously we have nice filling on the arterial phase, still good filling on the second phase. Intermediate collaterals, we're starting to get decreased caliber on the initial phase. We get normal caliber on the second phase, but slightly diminished caliber in a few areas. And then for our poor collaterals, obviously we have very poor filling, only a few vessels. This would be a collateral score of 1. So what are the selection criteria for thrombectomy in the acute window? So on our non-contrast head, we want to make sure there's no mimic, no tumor, no bleed, and we want an aspect score of equal to or greater than 6. And on our triphasic CTA, we need the proximal occlusion, and we need moderate to good collaterals. So basically anything above a 2. So in our current algorithm, we incorporate perfusion imaging in the 6 to 24-hour window. These are for patients with profound deficits who are previously functioning independently. We then follow this with CT angiography just to confirm the presence of the large vessel occlusion. This determines the volume of infarcted and potentially salvageable tissue by measuring the volume of tissue to which the cerebral blood flow is less than 30% of expected. That's considered an infarct or a core infarct. They also measure the time to maximum, or Tmax, which is a measure of the time it takes for contrast to get from the proximal vessels to the parenchyma. And a Tmax of greater than 6 seconds is considered at-risk brain. And then it calculates the mismatch ratio of the at-risk to the core infarct. And then obviously we want to confirm post with CT angiography. So what are favorable perfusion findings? A CT perfusion positive CBF of less than or equal to 70 ml. So basically this is the size of the infarct core. You want a fairly small infarct core. That way you don't have a large amount of brain that's going to be susceptible to reperfusion injury. A mismatch volume of greater than or equal to 15 ml. So you obviously want to have enough brain, enough salvageable brain to make it worthwhile for the risk of the actual procedure. And then you need a CT perfusion positive mismatch ratio of greater than or equal to 1.8. So here are just a few examples. This is a patient presenting with dense left hemiplegia. Obviously, there's a large area of Tmax greater than 6 seconds, so that's our potentially at-risk brain, 132 ml, so greater than 15. That's good. We have a small infarct core of 16 mLs, mostly involving the anterior temporal lobe and lateral temporal lobe, and a mismatch ratio of 8.3. So this would be a good candidate for thrombectomy. As opposed to this patient, where we have a large infarct core of 113 mLs and a Tmax of 126. So mismatch volume of 13, which is less than 15. We have a CBF of greater than 70, which is bad, and a mismatch ratio of 1.1, which is less than 1.8. So again, all parameters are not favorable for thrombectomy. So our selection criteria for thrombectomy in the extended window is, again, same thing on the non-contrast head: no bleed, no tumor, aspect score greater than or equal to 6, proximal occlusion, and then favorable perfusion parameters. Our current imaging algorithm, this is somewhat outdated, as they typically will go to the unenhanced head and then already have the CTA or the perfusion imaging done by the time we actually get there to make this decision. But as long as there's no bleed or mimic, we could stop there and do imaging based on the patient's presentation or the findings. If there's no bleed and no mimic, we go on to our aspect score, and if it's greater than or equal to 6, typically we proceed. This never happens. We never stop if they have an aspect score of 2. If it's the early window, we go on to collateral scoring. Late window, we go on to perfusion. And on our triphasic CTA, we want to do clot burden, measure or assess for proximal vessel occlusion, and then do our collateral scoring. Late window, again, we do our perfusion scan, favorable perfusion parameters, and confirmation of proximal vessel occlusion. A little bit redundant, but these are our good candidates for thrombectomy. Triphasic CT, acute window, proximal clot, aspect score less than 6, and intermediate or good collaterals. Late window, aspect score less than or equal to 6, CVF less than 70 cc's, mismatch volume greater than or equal to 15 cc's, and a mismatch ratio greater than or equal to 1.8. The posterior circulation. This is much less publicized, but equally important. Approximately 20% of strokes actually affect the posterior circulation. And always remember to include this in your initial screen. So look for hyperdense vertebral or basilar arteries, hyperdense PCAs. Look for signs of ischemia, and you can attempt to quantify with the posterior circulation aspect score. So PC aspects, you get 1 point for each thalami, 2 points for the midbrain, 2 points for the pons, 1 point for each occipital lobe, and 1 point for each cerebellar hemisphere. Again, for a score of 10. Just summarizing that. And there are several studies now that are being published assessing the potential benefits of endovascular thrombectomy in acute posterior circulation ischemia. The Basilar study came out in 2020. It showed a significant improvement in functional outcomes in patients with acute posterior circulation ischemia and basilar artery occlusion. The Attention study again showed a significant benefit with basilar artery occlusion within the first 12 hours. There was the Bayos trial, which extended that to 24 hours and again showed significant improvement. There are also some studies, including the BEST and BASICS trial, that didn't show any improvement in functional outcomes, and I believe it was BEST that showed actually there may be some potential increase in adverse events. So this is just showing some of the modified Rankin scores for the Bayos and Attention trials, which really show striking improvements, and it may just be related to patient selection, which is what they're still working on with a few of the studies as far as what makes the optimum patient selection for posterior circulation ischemia. BASICS trial didn't show a significant benefit, and the BEST trial actually showed worsened outcomes. So there have been a few summary papers now about what the evidence for endovascular thrombectomy and posterior circulation stroke is. A lot of them are saying, according to observational data, thrombectomy seems to be safe in posterior circulation occlusions with the proper patient selection. Again, this was in Stroke in April 2023, that based on the current evidence, EVT is highly effective in basilar artery occlusion patients with moderate to severe deficits and limited early ischemic changes within 24 hours of symptom onset. So really we are trending, and we will often treat these at our institution now with endovascular thrombectomy. So again, important to look at the posterior circulation always. What else? So on our CTAs, we always want to assess the arch, the carotids, and vertebrals, look for atherosclerotic plaque, characterize the degree of stenosis by NASCET, look for any irregularity or ulceration and composition of the plaque, look for other potential etiologies for vessel occlusions or stroke, such as dissection, vasculitis, carotid webs. Always look at the veins. Venous ischemia is still ischemia. Vascular malformations, any vasospasm or RCVS, and anatomic variations which may affect management, particularly in the setting of large vessel occlusion where they're going to be going in to do thrombectomy. And you obviously want to look at all the other structures. So just a summary, imaging has rapidly evolved from modality to exclude potential contraindications to a vital resource in the triage of patients for endovascular thrombectomy. Our current algorithms depend on the time from onset of symptoms. All patients first undergo an enhanced CT head to exclude bleeds and mimics and grade the aspect score. Patients in the acute window go on to triphasic CTA for confirmation of large vessel occlusion and collateral scoring. And then patients in the extended 6 to 24-hour window go on to CT perfusion and monophasic CT angiography to confirm large vessel occlusion and favorable perfusion parameters for EVT. So just one more time, that's CDF less than 30% of expected in less than 70 cc's, a mismatch volume of greater than or equal to 15 cc's, and a mismatch ratio of greater than or equal to 1.8. Always look for ischemia in all territories. So do your PC aspects, especially if you see a basilar occlusion. Look at your ACAs, which isn't included in the aspect score. Interrogate all vessels, basilar and posterior circulation, distal vessels, veins, drovia, and sinuses. And remember to look at the extracranial and extravascular structures. So we'll just go through a few example cases just to sort of drill this in. This is a 68-year-old male with right hemiparesis. Our aspect score that Rapid gave, and like I said, I don't get any kickbacks from Rapid. Their aspects rating is sometimes okay, sometimes far off. This one I would grade as probably a 10. There is a small area of possible penumbra or at-risk tissue in the left lateral frontal lobe, CBF of 0, mismatch volume of 13. So ratio is infinite. Would anyone want to go in and do a thrombectomy in this patient? I would argue no. There's less than 13 cc's of salvageable tissue, so potentially you're going to cause more harm than do good. Another patient presenting with right hemiparesis. Again, aspects is 10. This one I do agree with it. It's very rare that Rapid actually gives you an aspects of 10. And again, we have an area of at-risk tissue in the left frontal lobe, MCA territory. No areas of definite established infarct. We have a mismatch volume of 69 cc's and a mismatch ratio of infinite again. So this is an ideal candidate. This has a big enough area of at-risk tissue that it's definitely worthwhile going in to try to save. There's no infarct core. You could potentially, these are the patients that sometimes will wake up after their thrombectomy and be completely back to normal. So 65-year-old male with right hemiparesis, and aspects giving us an aspect score of 6, lentiform, which I agree with, or insula, and then they're saying M4 and M5, which, yeah, maybe. On our perfusion maps, we obviously have this large area of at-risk tissue, 153 cc's. We have a small infarct core of only about 14 cc's and a mismatch ratio of 10.9. So again, these are good candidates. This is a really good candidate for thrombectomy. Just want to confirm on the angiographic images that you do have a large vessel occlusion there. And here's just another case on the right hemisphere, another ideal candidate. This study does have a little bit of that motion that we were talking about earlier, Derek. There's a little bit in the occipital lobe. So on the motion maps, there was some motion, but there was a convincing area of at-risk tissue. 202 cc's, it's probably smaller than that, but we can't quantify because they are picking up that artifact. There's no area of infarcted tissue, and there was a proximal M1 occlusion. So this patient was a great candidate again for endovascular thrombectomy. This is just another thing to look for during your scan. Obviously, you have large vessel occlusions, but there are other things that can cause strokes that don't always have large vessel occlusions. So it was a young patient with significant irregularity of her right supraclinoid ICA. Charlotte, this may give you nightmares from, actually, I think you did very well in this case during the mock oral. So significant irregularity, narrowing of her right supraclinoid ICA in a 32-year-old patient, you got to think of things like dissection and vasculitis. She went on to vessel wall imaging and had circumferential enhancement of that vessel wall. So this was a patient with primary vasculitis CNS. Look for other causes. Again, look at all vessels. Like I said, you want to make sure you're looking at the veins as well. This patient has superior sagittal sinus thrombosis and cortical vein thrombosis with a little bit of ischemia in the right frontal lobe. So venous ischemia always has to be on the radar. And then just, especially in young patients, recurrent cryptogenic right hemispheric infarct. So localizing to one territory, young patient, cryptogenic, they haven't found any other cause. Really look at the cervical ICA for any possible carotid webs. All right, so this patient presented with right hemiparesis. See the unenhanced CT head. Nothing gross. So aspects of 10 on our CTA. It's very hard to see much as far as a vessel occlusion. Always look at your early and late venous delayed phase images. This is the early venous phase, and you can see that there's an area of prominent vasculature in the left MCA territory. If you go back, this will often help you find distal thrombi. If you look at the M2, sort of leading into that area, we have an area of non-opacification. So this is a distal M2 stroke or M2 embolus with resultant ischemia. Not a candidate for EBT, it's too distal, but we have a good explanation of their symptoms. It's one of the tricks with the triphasic CTAs, especially for the small vessel occlusions. They're not just useful for large vessel occlusions. Always look at your early and late delayed phase images, especially if you don't see any areas of ischemia or any definite intraluminal thrombus or abrupt vessel occlusion, because it's amazing how many times you'll see these little areas of increased contrast density or prominence in the peripheral vessels, and you can actually go back onto your arterial phase images and identify tiny M2, M3, M4 thrombi.
Ian, what is that increased density in the venous phase due to? Is it because the blood, what's causing that stasis?
It's essentially backfilling. So it's the arterial density of blood is just taking longer to actually get to that point. It's essentially stasis, or you could sort of think of it as a visual representation of the delayed transit time.
Thank you.
No problem. Okay, so this is another patient presenting with dense right hemiparesis. So on our unenhanced CT, we can see a very dense M1. As we come up, we're seeing early loss of areoid differentiation in the insula, in the caudate, in the lentiform, potentially in the internal capsule. There's subtle smudging of areoid differentiation when you compare to the contralateral side in M1 through M6 almost. So this patient already has extensive early ischemia. Your aspects is close to a 0. On our arterial phase, we contrast the two sides. You can see obviously we have a left ICA occlusion, which is extending into the MCA. Then as we come up, there's a very striking paucity of opacifying vessels in the left MCA and ACA. On our first delay, we again have a very striking paucity of enhancing vessels in the MCA and ACA. And even on our second delayed phase, there are essentially no vessels there. So this would be a poor collateral score. This is a 0 to 1. Obviously, this patient has a massive infarct as well, so this is not a good candidate for endovascular thrombectomy in the acute window. Any questions on that one? We got a few, there's a few collateral scores. This is going to get redundant, but I think it's important just to sort of drive home the point and see as many different collateral scorings as possible. So this is another patient. This one was presenting with left-sided symptoms. We have our unenhanced CT. Again, we see slightly hyperdense M1. Got early ischemic changes in the anterior insula. Can you guys see my cursor?
Yes.
Yeah, okay. Don't know if I'm just waving at nothing on your screens. There's loss of barrier differentiation in the caudate, the lentiform. The rest of the cerebral hemisphere looks okay. There may be a little bit of loss of barrier differentiation in the sort of M5 or M6. So aspect score of 6 to 7. So that's okay. This patient actually went on to perfusion. This was a late presentation or delayed presentation. So we have an abrupt cutoff of our right M1, so large vessel occlusion. And then even if you look on just our arterial phase images, if you look distal to that M1 occlusion, it's a fairly long segment occlusion. If you look at the vessels distal, it's really hard to say which side is affected if you're a little bit higher up. So this patient obviously has good-looking collaterals on the arterial phase. They went on to a perfusion, which showed a large area of potentially salvageable tissue, relatively small infarct of 16, salvageable 126 mismatch of 110 cc's, and a mismatch ratio of 7.9. So this was a favorable patient for endovascular treatment, and they did undergo thrombectomy with pretty good results. This is another late window patient. So as we come up, we have areas of loss of barrier differentiation, posterior insula, left M5 and M6. Question whether there's a little hyperdense vessel in the insula as well. We go to our CTA just to confirm that we do in fact have a large vessel occlusion. We see our M1 is actually pacifying fairly well, but our dominant inferior M2 division abruptly occludes in the insula, corresponding to that area, the little hyperdense vessel there. So M1 and M2, proximal M2, especially in dominant vessels, we would potentially consider as candidates. And our perfusion map on this delayed patient, we did have an infarct core of 30 cc's. There is a potentially salvageable area of 40 cc's, so Tmax 70, mismatch volume of 40, and a mismatch ratio of 2.3. So potential candidate for thrombectomy. This patient went on to thrombectomy and also did fairly well. Okay, so another patient presenting in the acute window. This is actually the patient that we did the aspects on in the actual PowerPoint presentation. We've got a little area of ischemia in the insula and a little bit in the frontal operculum. So aspect of 8. When we look at our CTA, you can see that there's an abrupt occlusion of the superior M2 division near its origin. So again, a proximal vessel occlusion. We have quite a paucity of vessels on the arterial phase in the expected territory supplied by that division. Starts to fill in, but again, not good caliber, not good contrast density in that region. And then on the second delayed phase, again, not great. So these would be low intermediate collaterals. We do have some vessels, they're decreased caliber, but they're not, there isn't a significant paucity. So a potential candidate for EVT if they're previously functionally independent. Okay, so another patient presenting with right-sided deficits. On our CT head, we can see this area of evolving ischemia seems to conform predominantly to the ACA territory. So again, a reason to look at different vessels. And when we look on our CTA, you can follow the ACAs. The ACAs actually look like they're patent, but there does look like there's a paucity of vessels in that region, so something's up. Then you come to the vertex and you realize that the superior sagittal sinus has a large filling defect. There are cortical vein thrombi as well. So this is an area of venous ischemia. And this one can be a little bit strange on triphasic CTAs. You can actually see there's an increase in the number of vessels in the left frontal lobe. This is just secondary to basically venous hypertension, venous reflux. And again, it actually worsens on the second delayed phase. Just another reminder to always look at all the vessels and to remember about venous ischemia. So another patient, this guy's presenting with left-sided weakness. See, it's a little bit tough to see, but looks like there's a slightly hyperdense M1 distally. And then on our stroke windows, we can see that there's a large area of evolving ischemia. We've lost our insula, starting to smudge the caudate lentiform, and then a large portion of the M1 through 6 as well is affected. And we can see we've got a distal M1 plot. Not a large amount of vessels in that MCA territory on the early phase, or on the arterial phase, sorry. On the early delayed phase, we do start to get some opacification. Slightly decreased caliber, slightly decreased number. So we're looking at intermediate collaterals. So this patient would probably have a 3 as far as the collateral scoring. Again, all we really need to differentiate is between poor and intermediate for candidates, but it's nice to give them a number as well. This patient did not go on to thrombectomy just because of the large amount of tissue that had infarcted at the time of their presentation. This is another example of relatively poor collaterals. Actually, sorry, this is actually a great case. I will show this one. This is actually good collaterals. This is a patient presenting with right-sided weakness, actually. As we can see, there's an abrupt cutoff of their left M1 segment on the arterial phase. There's early smudging of the caudate lentiform and insula. Arterial phase images, we've actually got fairly good flow distal. This is again like that other case that I showed you. We've got good opacification of the distal vessels, great opacification on the first delayed phase, really almost increased in number compared to the contralateral side. So this is a patient with good collaterals, score of 4. You can see it almost starts to wash out on the second phase. So they've actually got fairly decent transit through there. This is another patient. They have an abrupt occlusion of their left M1 segment with increased both caliber and density on the first delayed phase. So they have good collaterals. But this is unfortunately a patient where you want to look at all of the images. That's we can be fairly helpful in the upper chest as well. So this patient had undiagnosed adenocarcinoma of the lung. If you see that, just make sure you do a really, really close interrogation, even of the source images of the delayed, just to see if there are any enhancing lesions that may be occult, because they may predispose them to hemorrhage as well. Okay, we're starting to get to some slightly different cases. So this was a younger patient that presented with vertigo and pain in their neck. You can see on the unenhanced CT head, they do not have any definite ischemic changes. We're obviously thinking posterior circulation. There is a slightly hyperdense, questionable right V4 segment. On their CT angiogram, we'll just sort of cut to the chase. The right vert is a relatively normal caliber at the distal V2 into the proximal V3, and then all of a sudden becomes narrowed in caliber, slightly irregular as well in the V4 segment, and narrowed. And then we did this is what our T1 fat sat images should look like in cases of dissection. You can see the right vertebral artery. There's this very bright signal in the wall. You have a patent lumen that you can sort of see there. It looks almost like a little googly eye. So that is your typical vertebral artery dissection that we should be seeing on MR. I know we were talking about that the other day. So this is another case of a dissection. This patient was not known to have any underlying vascular abnormalities. They do have underlying fibromuscular dysplasia. You can see this irregularity. This is the unaffected side, significant irregularity in beating of the right cervical ICA. On the contralateral side, you can see that beating as well. However, this begins to taper to occlusion at the level of the petrous segment, or distal cervical segment. And then there is reconstitution distally within the petrous. They were, in fact, symptomatic and did end up having small, predominantly watershed infarcts in the left MCA territory. And another example, this one doesn't have the dedicated T1 fat saturated images, but on our T1 coronal images, you can actually see the intramural hematoma going up into the skull base. You can compare that to the contralateral side. Where our ICA looks completely normal. Okay, I think those were all of the cases, and I think I've run out of time as well. Are there any questions at all? I hope that wasn't too quick of a review or too redundant of a review on aspects. And
thank you so much, Dr. Moffatt. It was very nice.
Collateral scoring.
Ian, that is fantastic. And I was just wondering, there is so much of information here. Is it possible that when some of us are on site next, if we can maybe just have access to go through this lecture of yours alone, maybe just look at the imaging, if that's possible?
Absolutely. Absolutely. Yep. Yeah, anytime.
Okay. That's great. Thanks so much, Ian. I'll have to log off. Thank you. Bye-bye.
Okay, no problem. Take care.
Bye. Bye.
Can I ask a question?
Absolutely.
I've seen cases where they'll do EVT with an aspects lower than 6, like 4 or 5.
Yep.
Is there any evidence that you know of to do that, or is it just like a case-by-case thing? Or
it's a case. It's mostly a case-by-case thing. Some of the interventionalists are a little bit more. I don't want to say aggressive, but maybe proactive. If they think that there is potentially salvageable tissue, and otherwise the patient may be of significant or may have significant deficits afterwards, they'll go ahead despite a lower aspect score than that. I think Dr. Van Adel famously said, if they have a heartbeat, and they want me to try, I'll go ahead and do it. But yeah, it's the data based on the studies suggests that the benefit is for patients, as a general population, is for patients with aspect score of 6 or greater.
okay, thank you. Thank you for the lecture. The cases were great.
No problem. Thank you. Any other questions?
Thank you, Dr. Moffatt.
Okay. Well, we'll call it there then. Enjoy the rest of your day.
Yeah.